here with the definition. So basically, the definition of a spinal disorder is any condition with many possible causes that cause a damage or a deterioration of the spinal cord and or of the spinal nerves. And as I already said, these can have many, many different causes, and I will talk about that later on. I will first do a little recap of the anatomy of the spine, just because I think it's much easier to understand the symptoms that occur in these disorders if you really have in mind the anatomy that lies behind it. So first of all, the spine consists of vertebrae, so the bone. We have 7 cervical vertebrae, then 12 thoracic vertebrae, 5 lumbar vertebrae, and then the os sacrum, which consists of 5 vertebrae that are ossified together, and then the coccygeal part. Between the vertebrae, you have the spinal disc, which you can see here, and these have the use to like buffer axial pressure that comes from the head onto the spine. And also it is bent in a specific way. So the cervical spine is in a lordosis. Then we have a thoracic kyphosis, a lumbar lordosis, and the sacral kyphosis. So here we have an axial picture of a vertebrae. Here's the vertebral body that is anterior, and here the dorsal part of the vertebrae. And right in the middle here, in this hole, lies the canalus centralis, which holds the spinal cord. And then from here, from the spinal cord through this hole, which you can also see here in the lateral view, exit the spinal nerves. And the spinal nerves from here then go into the periphery where they, either in the thoracic area, just build the nerves that go around the trunk. But then if you're talking about extremities, they go to the plexi, and from the plexi, they form the peripheral nerves. Okay. So the reason for the symptoms that occur in spinal disorders is either a damage of the spinal cord itself, which is then called myelopathy, or damage of the spinal nerves, which is then called radiculopathy. And both of these show specific symptoms, which are also a little bit different from each other. And I will really focus on these 2 symptoms because I think it's just because the causes are so broad, but they all present similarly with either myelopathy or radiculopathy or both. So possible causes can be classified as originating from outside or inside the spinal cord. The causes originating from the outside of the spinal cord are much more common. And you can have things as spinal degeneration, for example, osteophytes, which is very common in elderly patients. Then you have things like vertebral fractures, tumors, hematomas, herniated discs, or also spinal canal stenosis. And the most common of all of these are the ones that I wrote in thick. So especially herniated discs, spinal canal stenosis, and spinal degenerations are the most common causes of spinal disorders whatsoever. Less common are the ones that are originating from the inside, which would be, for example, fluid-filled cavities as syringomyelie, blockage of blood supply, and vitamin deficiencies such as deficiency of vitamin B12, but also multiple sclerosis or autoimmune diseases. There are many other possible causes for this as well. So this is not a complete list, but just to give you an idea, and I think the most common ones are definitely in here. From here on, we come to the symptoms and the clinical presentation. We have some general symptoms which are not specific to radiculopathy or myelopathy, but which often occur. Those are back pain, For example, back pain, if it is in the cervical, if it's in the cervical spine, that is between the shoulders, or if it is in the lumbar spine, it would be much more in the lower back. Then radiating pain, sensitivity anomalies such as paresthesia or numbness, weakness up to paralysis, and changes in reflexes. As I already said, if we have a damage of the spinal nerve root, we talk about radiculopathy, and a damage of the spinal cord would be myelopathy. They present slightly different, but you cannot really see them as different, completely different altogether, because in many, many patients, they occur at the same time. So radiculopathy shows as general symptoms, which I've stated earlier, for example, back pain. Then you also have radiating pain. If it is in the cervical spine, you would have radiating pain to the arms. And if it's in the lumbar spine, you would have radiating pain in the legs. Also at this part, spinal disorders in the most of the cases occur in either the cervical spine or the lumbar spine. Sometimes they occur in the thoracic spine, but that's really, really seldom. Also in radiculopathy, you have a loss of sensitivity or paresthesia, which is like a tingling feeling, and a hyporeflexia, weakness, and paresis. And the specialty here in radiculopathy is that they present according to the damaged nerve root. So I put them here together. They're very common nerval root irritation syndromes that have to do with the nerve root that is compressed. The most common, which you can see here again, is C6, C7, C8, and then lower L3, L4, L5, and S1. And they show very specifically. So you have the hyporeflexia in reflexes that are very specific for this nerve root. The sensitivity loss and the radiating pain is very specific to the dermatome of the nerve root. So the dermatome would be an area of the skin that is supplied by one specific nerve root, and not only like one area that is supplied by a peripheral nerve, because a peripheral nerve always has structures that come from different nerve roots altogether. As I said, the nerve roots connect in the plexus and then go out as a peripheral nerve, which holds many different nerve roots. But then a dermatome is one area of the skin that is supplied specifically by this nerve root. And the paresis would be in a muscle that also comes with as being supplied by the nerve root. So if we talk about C6 syndrome, the paresis would be in the muscles of the biceps brachii and the brachioradialis. The sensitivity loss you can see here would be on the lateral arm and especially the thumb, and the hyporeflexia would be in the biceps reflex and the reflex of the brachioradialis. C7 syndrome is the triceps brachii. Then you see here the C7 is in the middle of the hand, and the hyporeflexia would be in the triceps reflex. C8 would show as a paresis of the hypothenar muscles, which are the muscles that are here on the opposite side of the thumb, and would also present sensitivity loss or radiating pain to the medial hand or and the forearm. And there isn't really a reflex that goes presenting to that. Then we go down to the lumbar spine. So we have the L3 with the quadriceps, so the thick muscle here on the thigh. And the sensitivity loss would occur here at the frontal thigh and the medial knee. And you have the patellar reflex. that would be low. L4 goes down, same muscle, also same reflex, just the dermatome where you would have your sensitivity loss or radiating pain would be different. So it's the frontal thigh and the frontal knee, but then it also goes down to the medial lower leg and the medial foot here. L5, once again, doesn't really have a reflex. The muscles that occur here is the extensor hallucis longus and tibialis anterior, so that there would be no foot dorsiflexion possible. So this is your leg and this is your foot, and you couldn't really raise it like this. And you can also see here the dermatome with the sensitivity loss is the frontal lower leg and the dorsal and plantar foot. Once again, there isn't really a reflex for this one either. S1 would show as a paresis of the triceps surae, so in the back of your thigh here. And you wouldn't really be able to do the foot plantar flexion. So you wouldn't be able to lower your foot like this. The sensitivity loss in this case would be on the lateral foot and on the back of the leg. And you can see a hyporeflexia in the ankle jerk or Achilles reflex. Okay. So from this, we will go to the myelopathy. So now deterioration of the spinal cord. General symptoms can be similar. So you would also have back pain. You would also have radiating pain, depending on where your myelopathy lies. You would also have a loss of sensitivity and strength, but that would be a little bit more unspecific than in radiculopathy. So it's not clearly limited to one dermatome, and it's not clearly just one muscle which is weak. On the contrast to radiculopathy, you would also have a hyperreflexia and a form of spasms. The reason for this is that if you look at it, so your motor function comes from the brain and goes as the pyramidal tract through the spinal cord to as the first motor neuron, which carries the information about the movement. And then on the area on where it would leave the spinal cord through the spinal nerve, it gets kind of connected to the second motor neuron, where it transmits the information for the second motor neuron to then go to the muscle and do the movement. So now if our cord has a deterioration, the first motor neuron is becoming damaged, and that always comes with hyperreflexia and spasms. Because so you have your second motor neuron, and it lies here in the cord where it would then enter. And there are the connection parts where it connects to the first motor neuron. And as the first motor neuron deteriorates, these spaces get empty, but it doesn't stay empty, but there are other fibers of other neurons that are, for example, responsible for reflexes and for sensibility that enter these empty spaces in connection on the neuron, on the second motor neuron. So because of that, you have a hyperreflexia, as in contrast in radiculopathy, where the second motor neuron is damaged, you have hyporeflexia. So this is the reason for hyperreflexia and spasms in myelopathy. You can also have ataxia, and ataxia is a form of movement. I wanted to show you a video that I found on YouTube. I hope this works. If not, please let me know. I hope you also hear what is being said.
The last gait that I'm going to demonstrate is the ataxic gait. The ataxic gait, the patient has difficulty narrowing the station and maintaining balance. So typically they'll have a wide stance and trying to maintain balance, and that there oftentimes will be unsteadiness in the trunk. So there may be some truncal titubation, which is an anterior-posterior tremor at about 3 hertz. And there's also a tendency to lunge or to jerk sideways, and the patient then has to catch themselves. Of course, one of the ways to bring out this particular type of problem is to narrow the station, asking the patient to walk
Madam,
ahead.
students can see the video, just can see slide.
Oh, they can't see it?
No.
Oh, okay. Okay. Yeah, that's a pity, but no worries. Okay.
Okay.
Can you see me?
Yes.
Okay, so I will just try to demonstrate it a little bit. I'm not as good as the video, okay? But
Dr. Sebano video na kiki pedi ki pasane sarana play kiki no that's to explain cues. Okay.
so it's mostly, you can't really see me that well, but a person would stand like this, and if they try to walk, they would stumble and fall a little bit like this. And the reason for that is, if the spinal cord gets damaged, it's not only the pyramidal tract that has the damage, but also the fibers that carry the information of the deep tissue sensation. So this is basically what tells your body where in the room you are and how you can move. So because of the deterioration of the spinal cord, your brain might not get that information. And this is why it cannot correct itself, and you would have this form of ataxia. But you have to note that ataxia does not, and also spasms, they don't occur in every case of myelopathy. It might occur, but it's not obligatory. Another symptom would be the loss of bladder and bowel function. So I just put this together so you can see it in comparison, the difference in the symptoms. So both have back pain, both have radiating pain, both have numbness, but in radiculopathy, it's according to the dermatomes, and myelopathy would be not strictly according to the dermatome. Weakness is the same. Radiculopathy, you have hyporeflexia because of a damage to the second motor neuron, and myelopathy would be hyperreflexia because of a damage of the first motor neuron. Also, in myelopathy, you might have spasms and ataxia, which you might not have you don't have in radiculopathy. So we go to the diagnosis. Your diagnosis is basically history taking, physical and neurological examination, and then you would also do some imaging. When you do the history taking, there are, apart from the basic history taking that you do always, there are some things that you should ask for specifically. That would be whether there's back pain, and if there is, where it is, and if it is radiating into the arms or legs. Then you would ask for sensitivity, for numbness, paresthesia, and you would also ask for which side it is on. You would ask for weakness. And for example, if you ask a patient about weakness, they might tell you something like, oh, I don't really feel weak, but sometimes I'm holding a mug or a glass and it just flings out of my hand. And I can't really tell why, which might already give you an idea that there might be something wrong in the cervical spine. You would also ask them about problems with walking. Sometimes they might also tell you, oh yeah, sometimes I'm just walking and then I'm stumbling, or I'm just tripping and I don't really know why, which might also be because of ataxia, but also because of weakness. Very important is that you always have to ask for so-called red flags. So red flags are certain symptoms that tell you that there is something urgently wrong, that there's an emergency, and you have to act immediately. And in this case, the most important red flag is whether there is loss of urinary or bowel control. Because if this is the case, it shows you that there's a very serious and acute damage of the spinal cord. And if you do not operate on it or treat it very soon, that it might progress and you might have a risk for paraplegia, which of course you want to avoid. Going to examination, you would of course do a general broad physical examination. You would also look at your patient very closely to see if maybe there's atrophy in some muscles, which might be a sign for the weakness. You would let your patient walk for you, where you can see ataxia, as I tried to demonstrate for you. You would also test for sensitivity and have a look at whether, if there's sensitivity loss, if it's strictly to the dermatomes. You would test your patient for weakness and see if there's weakness in the characteristic muscles. Then you would check for the reflexes to see if they're hypo or hyper. And especially important is that you do the reflexes in comparison to the other side. So you always have to check on both sides, because there's some people that just have a generally really low state of reflex and some that have a general really high state of reflex. So if you check on a patient and their reflexes are really low on both sides and in their whole body, that doesn't mean that they have radiculopathy everywhere. They just have a really low level of reflexes. But if they're low on one side and like the reflex is basically jumping your arm on the other side, you might know that there's hyperreflexia or the other way around. You can also do tests for clony, which would be a sign for spasms. You should check for pyramidal tract signs, for example, Babinski, and nerve root irritation tests like Laseg and Bragard. And I just want to cover Babinski and Laseg and Bragard a little more deeply. So the Babinski reflex is basically a strong rub on the lateral side of the foot to the toes. And yeah, you can do that, for example, with the back of your reflex hammer. It is negative if the toes do this movement, so they just go to the plantar side of the foot. And negative is good. So negative is physiological, but it is positive if your big toe does a dorsal extension and this other toes do also like an extension to the sides and also to the back. That is positive. And a positive Babinski can be there in myelopathy or in other damages of the pyramidal tract. So it might also be due to a damage of the brain. And the reason for that is that the Babinski reflex is a reflex that is originally in each and every one of us. So for example, if you do the test on babies, it will be positive, but that doesn't mean that the baby has a problem. In infants, it's just there. But then as our cord grows and we grow, our cord learns to suppress this instinct. So it becomes negative the older a person becomes. But then if there is, again, a damage to the cord, the suppression goes down again, and you can see the reflex again. The other one is the nerve root irritation test, which would show you radiculopathy. So first, you would test for Laseg. So that means lifting the straight leg up to roughly 45 degrees. And then Laseg is positive if the patient reports of pain in the back. If it is positive, you would check for Bragard. So you would lower the straight leg a little bit and then do a dorsal extension of the foot. So if you lower the leg, the straight leg, the pain would go away, and Bragard would be positive if the pain comes back up on the dorsal flexion of the foot. If both Lasik and Bragard are positive, nerve root irritation is very, very likely. So you might have radiculopathy. But in case of pseudo-Lasik, which would be that Bragard is negative, that mostly says that the pain comes from musculoskeletal dysfunctions and not from nerve root irritation. One confounder could be that these tests would also be positive in meningitis because the meninges are getting stretched during the test. Okay, so we go to imaging. The first choice for spinal imaging is always an MRI, and that is because it shows soft tissue very well. So you can see disc anomalies, you can see cord and spinal nerve root compression, you can see edema, and many more. X-rays would be indicated in case if you have a present red flag or a recent trauma or any other, for example, you suspect a fracture, because it shows bone anomalies such as fractures, but also tumors or degenerative processes. A CT is indicated in case of a also suspected fracture. It can be used for pre-operative planning or when an MRI is not available. It shows you bone anomalies, also space-occupying lesions and degenerative processes. I brought you some pictures. So here you can see a spinal X-ray, and as you can see, you can basically only see the bone. And this one is a normal spinal X-ray, so there are no pathologies in this case. And the other one is a CT scan. So you can see that you can see the bone very well, but you can also see a little bit more of the soft tissue around. So it's a bit better than an X-ray in terms of soft tissue, but it's not really good either. One thing that you can see here is that we have a fracture. And it looks like this piece of the bone goes into the spinal canal. So it might very well be that it compresses the spinal cord. And this would, for example, be an indication for urgent surgery, because otherwise you might risk paraplegia. Then we go to spinal MRI. And as I said, spinal MRI is really our first choice. Here you have T1, which is here, and you can see that the CSF, so the cerebrospinal fluid, is dark, and T2, where it is white. You might also have a T1 with a contrast medium, and then it's white again, but you will basically have it written down here if it's T1 or T2. Then the sagittal image here can show you myelopathy really, really well. So you can see it here on the picture below. Myelopathy is seen if, first of all, you see that there's something bulging into the spinal canal, but also if you have an MRI with contrast medium, myelopathy would absorb that contrast medium, as you can see it here, and it looks really, really bright. This one here might be something as spondylodiscitis, which is basically inflammation of the disc and osteomyelitis of the bone around it. So you can see all of this very nicely. In the axial view, you could see radiculopathy. So here you have anteriorly the bone, so the vertebral body, and here the dorsal part of the vertebrae. Then you have the central canal here, and this one here would be the nerve roots that exit. And if you see that there's no space here, and you have the clinical presentation of the patient that goes accordingly, you can see that you have radiculopathy. In this case, you can see that it's a disc protrusion, because this one here is a little bit darker than this part. So this is the protruded disc which went into the central canal and which compresses the spinal cord over here. Okay. So then we continue to therapy. So therapy, basically, I mean, it depends on what the underlying cause is. So you cannot really say it for everything. But for most of the causes, you would operate. However, if you have only unspecific back pain and your patient does not have any neurological deficits, you would basically go with pain medication and physiotherapy. For example, if you see that they have a disc protrusion and they have pain, but they don't have radiculopathy and they don't have myelopathy, you would still leave them with pain medication and physiotherapy. However, if you have pathologies as like a tumor or a hematoma, and especially your patient has neurological deficits or even red flags, or also in case of therapy refractory cause, so you administered conservative therapy before, but it doesn't help anymore, you would go into surgery and you would basically just remove whatever is there and whatever is doing the compression of the spine, a spinal cord or the nerve roots. But it's kind of, you cannot perform surgery for everyone, but then you still have to see what are the risks and what is the benefit of a surgery. Like if you have a disc prolapse, as I said, you don't have to operate, but if you leave it for too long, the symptoms might get stronger and stronger, so you still have to operate. If you have a stable fracture, you can also treat the patient conservatively. But if you have an unstable fracture and there is also, a risk for spinal compression, even if it's not yet there, you would still put the patient into surgery to fix it. Possible complications of these spinal disorders are basically permanent nerval root or cord damage or paraplegia. And of course, you definitely want to avoid that. The problem is the longer the symptoms are there and the more severe they are there, the less likely they are to get better or go away after treatment. So if they've been there for a long time and they've been really severe, even if you operate on them, it might not get better. And also for the symptoms, they usually come with the severity in a certain order. So first you would get back pain and radiating pain, then would come paresthesia, then would come sensitivity loss, and then motor weakness. So if someone comes to you and they already have motor weakness, you know the damage is more severe than in another patient that comes to you with just back pain, even if they have, let's say, both a disc protrusion. Prevention, this only goes for the degenerative causes because really, in fractures, you can say avoid trauma, but we all know that it's not that easy. But for the degenerative causes, also disc protrusion, spinal canal stenosis, prevention would be weight reduction, then physical exercise, and also physiological carrying of loads. So, yeah. Okay, so that would basically be the lecture. We could now go into the discussion.